Actually, such introduction is very well visible, and I don't think he requires introduction. But I can say he is the founder of the food care, and he is president in Indian Poultry Association. Fortunately, he is doing wonderful work. We have a setup in our clinic, like we used to see only eyes and tongues only. So we have due to according to our clinical setup, we are not never looking at the food. So he started looking at the food and joining many associations. So I would like I request sir to please give your introduction and lecture. Thank you.
Thank you, Chairpersons. Thank you, Dr. Dhruvi, Dr. Vipul, and RIM Hospital for inviting me in this forum. And we recently met in Pune, and then we discussed about diabetic foot care. And I think no conference of diabetes is complete without covering its complication. And diabetic foot is something which Dr. Dhruvi, as in her presentation, was saying that cost. We have to see the cost for our patient. And truly right that if I'm admitting my patient in my hospital, I work in Fortis Hospital in Delhi, I might discharge my patient, non-diabetic patient, in 2 days, whereas a diabetic patient I cannot discharge less than 5 or 6 days on IV antibiotics and developments and other things. If we look at the cost, a non-diabetic patient can get out of the hospital in something less than 50,000 rupees only, whereas a diabetic foot infection patient suffering with cellulitis, necrotizing fasciitis, or any type of diabetic foot infection, a minor infection in the middle part of the foot, on the plantar surface or on the dorsum of the foot, might not get a discharge less than 2.5 or 2 lakh rupees. That's the cost in Delhi, and I think same would be the cost in Ahmedabad also. So this is the dilemma that we have been suffering in our country. So way back in 2001, I came back, I did my podiatry from US, and when I came back to India, that was the thing that we wanted to start Indian Podiatry Association, because if we look at the data, which is similar as was 2 decades back, we might be touching something around 100 million people suffering with diabetes, and again 100 million are in pre-diabetic condition. So we should not be proud of this data. And I think everybody sitting over here would be seeing, when you are seeing patients in a day, 1/4 of your patient would be coming to you with peripheral neuropathy, peripheral vascular disease, tingling in the foot, sensation, autonomic neuropathy. So 1/4 of these patients would be suffering with foot ulceration, or 1/4 of these patients may require amputation. So I think this session of this conference, Practical Diabetology, should be that how we can prevent amputation in our patients. So I'll be going through my slides. I have 2 presentations, and we'll be giving you some take-home messages to try to catch hold of those take-home messages. Most of the things I'll be covering into a practical thing. Diabetes, we know, is the leading cause of non-traumatic lower extremity amputation, and a simple foot ulceration is a precursor to about 85% of all lower extremity amputation. And there's the history coming up in India now that more than 2 lakh amputations annually they occur in India. And again, shockingly, less than 50% of these amputees, they achieve the mobility, and cost is one of the factors. If the breadwinner of the family and loses one leg, and how you can see the prosthesis, he's type of out of the job for so many days or weeks together or months together, and that is the cost to the whole family of these patients. If we look at the disease burden of these diabetic foot infection patients, a lot of things are there, but I'll be just going short into these 2 in purple. Prevalence in Asia is about 5.5%, and prevalence in India is something around 11.6%. So hugely high diabetic foot infection patients. And that is what I am also seeing in 2 decades of my practice. When I came back from India, how many less patients you are seeing. And if you yourselves, there are very senior doctors sitting over here, and if you see a span of 10 years in your practice, you will be seeing that diabetic foot, you are seeing more of the complication, because the geriatric group is increasing, more patients are having insurance, the quality of lifestyle is increased, they are having more medical benefits, and so the life expectancy is increases, so is the complication of diabetes. You have more, you go to any dialysis department, they are all full. Recently, I had one of my friends coming from Hyderabad, and being in Fortis Hospital, he was on dialysis, he stayed there for 2.5 days, he is a doctor friend, and I got difficult to get a dialysis in my hospital. We got 3 a.m. slot for him. So see how thing is there. So many people suffering with CKD, and so many people suffering with diabetic foot ulceration. You will see these are the two parameters, and I think these to be the goal, that how we have to early detect diabetic neuropathy and early detect peripheral arterial disease, because these are the two complications which severely affect patients suffering with this. And how a simple ulceration forms. It is mainly the glycosylation, the long-term diabetes who have 10 years of diabetes, 15 years of diabetes, they get hyperglycosylation of the tendons and ligaments, mainly the plantar fascia on the lower part of the foot, or the Achilles tendon at the posterior part of the heel. If you can increase the mic, volume of the collar mic. So that is the thickening of these Achilles tendon and plantar fascia. It makes the foot rigid. What happens in a diabetic foot patient, that they have sensory neuropathy, along with that they have motor neuropathy. So this is a ground and the patient is walking on the heel, and as the patient puts the foot on the heel of face, and when he's at the toes, he doesn't have the gripping on the footwear. Because of that, it goes into a clawing of the toes. And also there's a formation of calluses on the foot. Why the calluses form? You see your foot on my foot, when we see, we will not find any calluses. There's biomechanical abnormality, then we'll find calluses. Calluses are the indicator of hard skin. That is a high pressure. In most of the diabetic patients, you will find calluses. I'll show you some photographs there. Because we have done MRI studies and seen that there's an anterior deviation of the fat pad tissue. God has given us fat on the plantar surface which act as a cushion. So a child is born, he starts walking from 2.5 years or 3 years. Till the time of death, we are walking on our foot, and that is the fat pad tissue which gives a cushioning to the foot. In diabetic patient, there's an anterior deviation mainly from the metatarsal heads, because there's a high pressure area. So clawing of the toes makes the foot rigid, and because of that, these calluses, they form over there. And when we see these, most of the patients, they will develop these calluses over here. And then if the patient keeps on walking, this is the place that we should catch these patients. Those three things we have to do. I'll just cover in next 2 slides three things we have to do. But if patient keeps on walking on this callus, there will be subcutaneous hemorrhages. The callus will break down, and that will lead to the formation of an ulcer. So this is one thing that we have to prevent in most of our patients. And this is the frank diabetic foot ulcer patient who comes over here. Now this patient doesn't have any pain. He is walking on that foot because of the pressure and because of the insensate foot. 3 high risk factors are peripheral neuropathy, peripheral vascular disease, and altered biomechanics. Patient might be having bunion, patient has hammered toes, hemming of the toes, he is wearing tight shoes. Because of the tight shoes, he can have infection at the interdigital or interphalangeal joints. He can have infection at the first MTP joint or the fifth MTP joint on the posterior part of the Achilles. So altered biomechanics is the main culprit in diabetic patients. So whenever you see these patients coming to you for sugar control, always do the foot examination, look at the biomechanics, if he has bunion, if he has flat feet, high arch foot, clawing of the toes, hammering of the toes. Proper education should be given to these patients. Now, the role of a diabetes educator is very important. As we are giving care about the sugars, insulin, hypoglycemia, we have to give them care about the foot also. So 5 things are important. Interdigital maceration of the skin. We should advise patient to use alcohol swabs, clean it after they shower it, because the moisture leads to the formation of tinea infection or fungal infection there. Nail cutting. Most of the patients, they can't cut the nail. They say, मेरे पास clipper नहीं था, the nail cutter don't goes there, thick nail becomes thick. So some family members should cut. Many a time patient comes with when they cut the nail, they cut the skin also, and that is an underlying PVD. Now underlying peripheral vascular disease is the main culprit. These patients, they land up in the gangrene of the first toe or any of the toes by simple nail cutting. So family members should be advised to cut the nails. Cracks in the field, they have autonomic neuropathy, dryness is there. So most of if you see the ladies, they are walking barefoot in the house, so they get cracks on the heel, and that is the portal of entry for the bacteria into the foot. So that we have to prevent them. Use any moisturizing cream, any coconut oil, mustard oil, tell them not to walk, but skin should be kept moist. 4 things are very important. Neuropathy, deformity, it leads to the high pressure areas. Peripheral vascular disease, it is a main culprit or delivering gangrene and amputation of the foot. But penetrating trauma and ill-fitting shoe wear is very important, so we should take care of these in this. This was a patient who was walking in a hot marble in Mathura. There's a 2.5 kilometer long Vrindavan Mandir, you must have heard about it. So you and me will be running on these marbles when we are walking. But diabetic patient, they will walk walk normally on the hot in June and July, in the hot summer. And this was a chief, one of the senior advocates of the Supreme Court. He went to Mathura, and on the way back, he was already my patient. In the way back, he came, he called me, and he was having blisters on the foot. So we have to give them a sole, and then hydrogel was given to this patient, and it healed in about 2 to 3 weeks of time. But this is something, yes, education is very important in very educated class of patients also. We have to tell them every mandir, gurdwaras, they have that mat kept of rank. So we should advise them to walk over there. But on religious purposes, sometimes they miss that. Most of the peripheral neuropathy patients are underdiagnosed, but when we examine them, they have reduced vibratory sensation, reduced pressure sensation, and reduced reflexes. Hence, periodic evaluation is very important. You should always examine these patients. And how you have to examine? Mainly with a 10-gram monofilament. This is again an insensate field. You can see the probe going from the plantar surface, going from this. But this is something we should not miss. As a clinician, as a diabetologist, your staff or you should be well trained enough, and you should keep multiple filaments should be kept in every drawers, every rooms of your clinic. And if we apply that at 5 or 6 places, and we ask the patient, if they are not able to perceive it, that means they have some insensate neuropathy. And proper education about the footwear, these not to walk on the hot marble, not to use hot water bottle, not to keep in front of the heaters like November and December when we have a warm winter, cold winters that time. So this type of education should be given to these patients. And also we should be palpable. If you come to my clinic or any of the hospitals, Dr. Dhruvi's hospital, they are worth, the podiatry clinic is worth about lakhs of rupees. So even the plantar pressure cost about something 16-15 lakh rupees. But I think 10-gram monofilament and doctor's own hand, they should be the sufficient enough if you have to really prevent amputation in your patients. So you should take off the shoes, take off the socks, and palpate dorsalis pedis and posterior tibial artery. If you can palpate that with your fingers, you can see if the pulses are low volume, if they are not able to feel, then you send them for Doppler scan or ABI index. But doctor's own examination and 10-gram monofilament, this is sufficient enough not to get any of the costly gadgets. Ankle brachial index, this is also very gold standard. We can apply a normal sphygmomanometer on the leg of the patient and put the handheld Doppler on the dorsalis pedis artery, and we calculate the ankle systolic pressure. ABI stands for ankle systolic pressure divided by brachial systolic pressure over here, and normal is 0.9 to 1.2. If it is less than 0.9, between 0.6 to 0.9 is peripheral arterial disease, or less than 0.6 is critical limb ischemia, then you have to refer these patients to a vascular surgeon and get CT, MR angiography or carbon dioxide angiography according to his renal profile. But referral to a vascular surgeon is very important in this patient. These are some of the patients who went on a pilgrimage. They were wearing tight shoes, underlying PVD. This was missed by a physician or a diabetologist. This patient has PVD for something around 10 years, and he went to Badrinath, and he was wearing a shoe, and within 2 days he developed the necrosis of the throat. So this is not something that he can develop in 1 or 2 days. PVD is underdiagnosed for many years. So that's the thing, that we should do Doppler scan, and pulse examination is important for these patients, and proper education and simple shoe bite can lead these patients to this. Another very group of patients are in diabetic, these patients, when we do examination of these patients, when we do ABI index, so they are falsely elevated. Calcification is a big problem in this patient, mostly with CKD, patient on dialysis or long-term diabetes. A simple 200 rupees X-ray can give us a picture of calcification, and that will need that these patients, if they land up with an ulceration, it will be a problem from this days. If we need to prevent the amputation, we have to work on the stairway of neuropathy and peripheral arterial disease examination, because this will lead to infection, wounds, gangrene, and then amputation can occur in these patients. But I think this is one of the take-home messages, METADOR. You should always remember this. M stands for metabolic control. As we have been discussing since morning, metabolic control or sugar control with insulin, with OHS is important for all diabetic foot patients. Also, we have to look for albumin contents, electrolytes, and other things. We have to do assessment of a diabetic foot infection. Debridement is very important. Do not be hesitant of all necrotic dead tissue should be removed. And antibiotics. Now, very important is how to identify the biofilm. Most of these diabetic patients, they are chronic wounds. In a chronic wound, the big problem is if you take the culture, we have to teach our staff how to take the culture. Biofilm, you don't need to take culture from that. That will give you all resistant bugs. You don't need to treat biofilm. So wash it with normal saline, slimy layer, remove it, and then take the culture from the inside, and then give the antibiotic into this. Dressings, offloading, and referral to a vascular, plastic, orthopedic surgeon or other fields is very important. And last, E stands for education. This is also very important in patient because we need to educate our patient. To prevent amputation, we have to, lot of things are there. In the second part of my presentation, I'll cover the new treatment modalities into VAC, PRP and everything. Vascular intervention is there. Dr. Rishabh is here. He'll be covering into critical limb ischemia. Footwear, patient education and prevention of re-ulceration is also important. Most of the foot problems are preventable if early identification and prompt treatment by skilled health professional is done. But if we look at primary prevention and secondary prevention level, we have no successful trials. Metabolic control, yes, HbA1c control is very important in these patients, and smoking cessation. And if we look at secondary prevention, we need to identify high-risk food. Patients who have altered biomechanics, peripheral arterial disease, insensate food, neuropathy, foot education about the shoes, foot care and management for active problem should be given to this patient. One of the innovations are temperature monitoring, surgery to improve active monitoring, shear reducing insoles and neuropathic footwear. These are all very important part into this. These are the thermometers which can give to the patient and see the temperature, rise of temperature in the patient, and they're developing cellulitis or Charcot foot. This is again a preventive model, and advanced monitoring by infrared temperature is also there, which can again prevent the major amputation on these patients. This is simple this. I'll cover this in the second part of my slide. Key messages: we need to stratify, educate, identify the problem, and dry skin is very important. You need to treat the dry skin, whether neuropathy, the autonomic neuropathy or any ulceration, and skin integrity should be maintained in these patients. Thank you so much.
Thank you very much, sir, for this very insightful talk. Now I would...
Dr. Rishabh. Yes.
So I would like to invite on stage Dr. Rishabh Gadvi, sir. He is a very skillful surgeon. He is a member of IMA, Gujarat State Surgeon Association, Gujarat Vascular Society of India, European Society of Vascular Surgery, Chennai Vascular Society. He has published various publications in national and international journal. So over to you, sir.
Thank you for the introduction. Good afternoon, everyone. Myself, Dr. Rishabh Gadvi, vascular and endovascular surgeon at Indovasc Hospital, that is Center for Veins and Vascular Surgeries. Under one roof, we three vascular surgeons are there. Dr. Sujal Shah, senior vascular surgeon, myself, Dr. Rishabh Gadvi, and Dr. Yash Patel. I'll start my presentation. Topic is critical limb ischemia in diabetics. So if you go for the definition, any rest pain more than 2 weeks of duration or tissue loss in form of ulcer or gangrene, it's called chronic limb ischemia. And nowadays new term is chronic limb threatening ischemia. And diabetes has 2 to 4-fold increased risk of developing CLI. So 25% of the diabetic will develop foot ulcer in their lifetime, and more than 20% of diabetics develop peripheral arterial disease. And after 1 year of diagnosis, 25% will die and 30% will require major amputation. The 3-year limb loss of 40%, and not only in the same limb, 30 to 40% amputee will require contralateral amputation within 3 years. So it carries major burden of disease. So 50 to 60% of non-traumatic amputations are due to diabetes. So in world, 1 amputation is happening every 30 seconds, and diabetes are 25 times higher than non-diabetic to have amputation. If we go for the pathogenesis, so chronic hyperglycemia will produce advanced glycation end products which produce excessive reactive oxygen species and activation of protein C kinase, and which cause low-grade inflammation, vasoconstriction, thrombotic abnormalities, arterial stiffness, endothelial dysfunction, microvascular dysfunction, and eventually leads to peripheral arterial disease. So CLN in diabetics are more challenging because 50% of patients don't have a history of claudication due to neuropathy. And it is more distal in nature and diffusely affected in the arterial system. Even we will see that extensive calcification, stiff arteries, rock hard arteries due to media sclerosis, and with that associated kidney disease and hypertension, which also increase the risk of cardiovascular events, including MI, stroke, and overall mortality. And other challenges are that lack of knowledge about the disease among the general public. Majority of the clinicians still thinks that everything related to arteries is Buerger's disease. In periphery, still lumbar sympathectomy is commonly performed, and believe that dry gangrenous toes must be amputated in emergency without treating the main cause or revascularization. And generally, we don't believe in palpating pedal pulses, and this type of cases generally come as a delayed presentation. So if we see the pattern of disease, we generally divide in 3 segments, that iliac segment, femoropopliteal segment, and below the knee vessel, tibial segment. So combined is 8%, combined femoral and tibial will be 60%, so majority will have femoropopliteal disease, and isolated tibial disease is 32%. And we will see extensive calcification, and most of the patient will have Rutherford class 5 and 6, which is minor to major tissue loss. So for the diagnosis, simple test can be done at the bedside, like ABI, ankle brachial index. So 0.9 is normal, less than 0.5 is critical limb ischemia. But in diabetes, due to extensive calcification, vessels will be non-compressible. So generally, ABI has its role is not that much important, but toe brachial index is more important than ABI, because digital arteries will be spared in that calcification process. So TBI less than 0.3 is called critical limb ischemia, and transcutaneous pressure of O2, that is also more than 30, less than 30 is called critical ischemia. So in advanced imaging, we can have duplex ultrasound. We can start with duplex ultrasound, in which amount of stenosis and occlusion can be seen. More than 50% we should consider for management. But main is CT angiography, in which we'll get to know extent of occlusion and even collateral formation and how is the distal reformation. But in diabetes, because of calcification, problem is that below the knee vessels, imaging modality, images won't be as good because of that severe calcification. In that type of cases, MR angiography is a better option. But among all this, that gold standard is digital subtraction angiography, because during that evaluation, we can even do therapeutic intervention also. So gold standard would be digital subtraction angiography. The modality of the intervention is based on extent of foot ischemia, whether in claudication to rest pain to tissue loss, evaluation of arterial anatomy, which segment is affected, angiosome concept, which I will discuss later on, and patient's comorbidity, whether fit for open or endovascular surgeries. We have that wound classification system, Wi-Fi, which has component of wound, ischemia, and foot infection. It has stage 1 to 4, and it suggests that major amputation risk at 1 year. So stage 3 and 4 has amputation risk of 25 to 50%. So we should revascularize in those stages. Angiosome is a 3-dimensional tissue block supplied by its mainstream artery. Like anterior tibial artery majorly supply that lower anterior aspect of leg, ankle, and dorsum of foot. Same way, posterior tibial artery supplies calf, heel, and plantar aspect, and peroneal artery supplies lateral aspect of foot. So angiosome suggests that we should treat artery, like if ulcer is on the or gangrenous patches over the dorsum of foot, then better to revascularize anterior tibial artery rather than other arteries. So for every diabetic foot ulcer, we should evaluate for signs of ischemia, infection, and neuropathy. The simple ABI and hand Doppler test we can do. If these tests are abnormal, we should go for vascular ultrasound and other imaging studies. But if these tests are normal, then also any diabetic foot ulcer that does not heal within 6 weeks despite good wound care, we should go for the ultrasound and other imaging studies. And urgent revascularization is needed when ankle pressure less than 50, toe pressures less than 30, and TCPO2 less than 25. Medical management also has its role in claudication patients and post-revascularization. So in antiplatelet, we generally use aspirin and clopidogrel. Statin, we use silastazole and pentoxifylline, which had an anti-restenosis property and antiplatelet action. And generally, we don't use vitamin K antagonist due to non-compliance, because it will require that frequent INR monitoring and restricted diet. The newer oral anticoagulant, commonly we are using rivaroxaban. Combination of NOAC and antiplatelet has good effect on peripheral arterial disease. And not only on that, it will also reduce the risk of cerebral